Okay, you've clicked on this very topic because you're looking for pieces of information on hypothyroidism, right? Or you've received this notification because you have subscribed to my channel. That is great. Well, either as a subscriber or you are visiting or you're just browsing, you've made the right choice to come here to get pieces of information on hypothyroidism. And I promise you, by the time we'll be done, you will have no question or questions to ask anyone. But before going further, let me say a big thank you for visiting. Remembering to subscribe if you haven't, sharing my presentations with all your friends on your platform everywhere, and listening to this very one on hypothyroidism. You've probably heard about hypothyroidism before, okay, or you're diagnosed with it, or you are treating someone that is already diagnosed with hypothyroidism. All right, hypo simply means something is low. Thyroidism is relating to the thyroid gland and its hormones. So it is fair to say that all we'll be talking about here will be hypofunctioning thyroid gland. Lots to know. Don't be in a haste. Relax. You will get everything you need to know when it comes to hypothyroidism. Let's go. At a glance, let me take you through some topic that you're going to find on my channel. Goiter, number 18, myasthenic syndrome, thyroid hormone synthesis, the effects of iodine, the thyroid hormone actions, normal and abnormal thyroid function test, hypothyroidism, hyperthyroidism, lymphedema, Hashimoto's thyroiditis, Graves' disease, thyrotoxicosis, thyroid storm, subclinical hypothyroidism, and subclinical hyperthyroidism, and of course, the brief anatomy of the thyroid gland. The thyroid gland. This is a small gland with big effects. When we'll start going through everything on hypothyroidism, we will know that the thyroid gland can affect the entire body from head down to the toe. Today, why is it that the thyroid gland will be hypofunctioning? Why is it that it will not produce enough of its hormones? And what would the effect be? And what is causing that? All this will be addressed today. So the organ that we are concerned about today is the thyroid gland. Okay, here's the joke. Do you really have butterfly in your neck? Let me get some responses. If you say yes, you're not wrong. If you say no, you're not wrong. We don't really have butterfly, see this very one, we don't really have it in our neck, okay? But we have a small butterfly-shaped gland, and that is our thyroid gland. You may not see, because we don't even expect you to do. When it is large enough that you can see it, then there's a problem, okay? And it is below the Adam's apple. Now, the thyroid gland by sketch, and kindly pardon me, I'm not a great artist, just for you to have an idea of where we have the thyroid gland and associated structures. As a matter of fact, not all structures are depicted here. No nerve connections, no blood vessels right here, no parathyroid gland indicated here. So this is my head, my ears, and the front of my neck. This is my shoulder. And then the upper part here is the hyoid bone. Then we have cricothyroid ligaments, and this is the thyroid cartilage. And cricoid cartilage is right here. And you can now see the thyroid gland. The thyroid gland will have the right lobe and the left lobe. And the part connecting the right and the left will be the isthmus. And here you could see the pyramidal lobe growing up towards the eye bone. And then below the thyroid gland is the trachea, meaning the thyroid gland is anterior to the trachea. That is why when there's enlargement of the thyroid, either goiter or cancer, then there can be compression of the trachea. Okay, back to the neck, because that's where our business is, that's where the thyroid gland is located. Although the effects of hypothyroidism will be throughout the entire body, we're back there at the anterior neck. And pardon me, the raw sketch, actually it was raw, that I've shown on the previous slide did not contain every structure that could be found at the anterior neck. But we need to know that the blood supply will also pass through that to the thyroid gland. Also, drainage, will also be through the same place into the internal jugular vein. You've seen the eye bone, you've seen the thyroid cartilage that is below the eye bone, you've seen cricoid cartilage that is below the thyroid cartilage, and you've seen the thyroid gland that is inferior to cricoid cartilage. And the cricothyroid muscle that will be connecting the thyroid cartilage to the cricoid cartilage, just below the Adam's apple. Don't worry, there will be a separate presentation on the neck anatomy showing the thyroid gland and all other structures, not just in another presentation entirely. Now, the thyroid gland anatomy fully. In a normal adult, thyroid gland weighs about 10 to 20 grams. By volume, men have more than women. The older you are and the bigger your weight, the more the volume. Volume will, however, decrease with increasing iodine. Thyroid gland is well vascularized. It is caudal to larynx, meaning if you go from head down to the toe, you first of all get to larynx before you get to thyroid gland. Thyroid gland is anterior to trachea and slightly lateral. Thyroid gland lobes and isthmus. There are two lateral lobes with superior and inferior poles. Thyroid isthmus will connect the right and left lobes. Isthmus is covering the second and third tracheal rings with a pyramidal lobe that is going up to the hyoid bone. The pyramidal lobe. The pyramidal lobe grows superiorly to hyoid bone and can harbor a thyroglossal duct cyst. Pyramidal lobe is not found in all people. And somebody is asking, if it is not found in all people, then why are you bothering me with it today? Well, let's get down. You'll see the reason. Men mostly will have pyramidal lobe, and it's just in about 55% of all human beings. The significance of pyramidal lobe and why I'm talking about it is that when there is the need for thyroidectomy, and the suggestion is that the patient should have total thyroidectomy surgery, then the surgeon must make sure that the pyramidal lobe is also taken off. If not, the surgeon will be leaving behind some thyroid tissue, thinking total thyroidectomy had been the case, but the pyramidal lobe will now continue to produce thyroid hormones. The succacan. Posterior to each lobe is a pyramidal extension of the tubercle or succacan. Through this tubercle will be the recurrent laryngeal nerve that will traverse posteriorly. Ectopic thyroid tissue. Ectopic thyroid tissue is possible along the path of thyroglossal duct as lingual thyroid found in the base of the tongue. Lateral aberrant thyroid is found in the lateral vagal lymph nodes, mostly indicating metastasis. Other ectopic thyroid size will be discussed fully under hyperthyroidism. The blood supply to the thyroid gland. Superior thyroid artery is the first branch of external carotid artery below the eye bone, and this will supply the thyroid gland and also 15% of our thyroid gland. So also will be the inferior thyroid artery that will be a branch of thyroid trunk from the subclavian artery. This will supply 85% of parathyroid gland because parathyroid gland and thyroid gland are together from the name parathyroid and thyroid, okay? So the blood supply to parathyroid gland will be 100% from superior thyroid artery and inferior thyroid artery. If you add 15 plus 85. Thyroidal artery will be found in only 3% of human beings, and that will take its root from aortic arch or brachiocephalic artery, sometimes from subclavian or internal thoracic artery. The thyroidal artery can be enlarged in goiter or in hypothyroidism. The venous drainage. Superior and middle thyroid veins will drain into internal jugular vein, while the inferior thyroid veins will drain into right and left brachiocephalic veins. The nerve supply. This will lead us to the autonomic nervous system. The sympathetic nervous supply will be from superior, middle, and inferior cervical ganglion of the sympathetic trunk. The vagus nerve will be the mother to the parasympathetic part. That will supply the parasympathetic fibers to internal branch of the superior laryngeal nerve that will be subserving the sensory function, and also to the external branch of superior laryngeal nerve that will be subserving motor function. The right recurrent laryngeal nerve is slightly above the nominate artery at the level above the subclavian, and that will be subserving motor and sensory to the larynx. The left recurrent laryngeal nerve will be from left vagus at the level of the aortic arch. But the non-recurrent laryngeal nerve is also in existence, but not in many people, just in 1% of the population. So, 99% of human beings will have recurrent laryngeal nerve, right and left, while non-recurrent laryngeal nerve is also possible, but in 1% of the population. The lymph nodes of the head and neck. I will not bother you with this because we're not dealing with cancer involving the thyroid gland today, but if I have reason to make reference to this, I will do for sure. So you can pause and go through this list. The parathyroid glands. Yes, we cannot overlook parathyroid gland, though they are in close proximity to the thyroid gland, but they function independently of the thyroid gland. Recurrent laryngeal nerve is anterior to the superior parathyroid gland and posterior to the inferior parathyroid gland. Thyroid hormone synthesis. We need to shed light on why we are running into hypothyroidism. We need to know how the hormones are produced and why we are having less of those hormones being produced right now. The situation known as hypothyroidism. So, we want to go into that. Let's go. Why bothering ourselves about thyroid hormone synthesis? Thyroid hormones are pretty important. Why? Thyroid hormones will determine brain and somatic development in children, and it will regulate metabolic activities in everyone. The thyroid hormones will affect the functions of all organs. So, very large quantity of the thyroid hormones will be stored to meet up with all these requirements. Biosynthesis and secretions of thyroid hormones. So, synthesis and release or biosynthesis and secretions are maintained by a regulatory mechanism that is very sensitive to minute changes in circulating hormone concentrations. Anatomically, thyroid gland has spherical follicles. Each follicle will be containing a single layer of follicular cells and has a lumen filled with colors known as thyroglobulin. The thyroglobulin. This is a glycoprotein produced by follicular cells of the thyroid gland. It is the main precursor to thyroid hormones. The thyroglobulins, tyrosine plus iodine, and will later click. Tyrosine iodination is catalyzed by thioperoxides in the follicular colloid. So, thyroglobulin will act as a substrate for the synthesis of the thyroid hormones. The T4 and T3, as it is known as tyrosine and triiodotyrosine respectively, are the final products. So, T4 is tyrosine, while T3 is triiodotyrosine. Still on thyroglobulin, the inactive thyroid hormones and iodine are stored within the follicular lumen. T3 and T4 are attached to thyroglobulin and form the colloid within the follicle. Thyroid-stimulating hormone will lead to the cleavage of the colloid by proteases. And what would that lead to? That will lead to the release of thyroglobulin from its T3 and T4. The T3 and T4. T3 and T4 are the active forms released into the circulatory system. Thyroglobulin is recycled back into the follicular lumen to be used again. T3 and T4 can be unbound or bind to plasma proteins. Let me quickly re-emphasize this before moving away, because some literature will tell you that T4 is inactive. Not completely wrong, but let me tell you, it is just that T3 is the most active form. T4 is also slightly active, but not as active as T3. And that is why T4 will be peripherally converted to T3 to have biological activity and effects all over the body. T4, T3, and reverse T3. T4 is about 90% of thyroid hormones that will be synthesized and secreted. The T4 will have 4 iodine atoms, with 2 of those atoms on the phenene or outer ring, while T3 will have only 1 iodine atom at its own outer ring. If an iodine atom is removed from T4, even the kids in grade 1 will tell you they will find T3. T3 is 3,5,3 triiodotyrosine, and that will be about just 9% of total thyroid hormones that will be secreted from the thyroid gland directly. But remember, T4 will be converted peripherally to T3. Don't worry, we'll get into all those right here. Okay, reverse T3 is 335. We can see that T3 is 353, so it is reversed here as 335 instead of 353. That is just about 0.9%. And good to know, right? Because we don't really need it. It's biologically inactive. Most of this reverse T3 is not from the thyroid gland. So we are stopping on this now. We're moving on to thyroid hormone synthesis. The role of the iodine here. Let's see. Iodine and thyroid hormone synthesis. We've seen everything about T3, T4, thyroglobulin, and so on. So is iodine playing a good role? Let's drive this car and get to that bus stop. Okay, we are now at the iodine bus stop. Iodine could be acquired from sea salt, iodized salt, seafood, seawood, kelp, dairy products, and vegetables. Dietary iodine. Dietary iodine is absorbed as iodine and rapidly distributed in extracellular fluid and is transported into the thyroid gland, because if it doesn't get there, The effect will not be known. And it will be excreted via urine. So renal function test is necessary when we're dealing with thyroid gland. Iodine deficiency. Iodine deficiency will be categorized based on the value of the iodine in urine. It is mild when we could pay 50 to 99 microgram per liter in urine, moderate when it is between 20 and 49 microgram per liter in urine, and it is said to be severe when we have less than 20 microgram per liter in urine. Effects of iodine deficiency. Of course, if there's no effect of it, then why do we need to bother ourselves? Okay, fetuses and infants will be dealing with severe growth and mental retardation if there's iodine deficiency in them. Batch to here, right? There will be thyroid enlargement, goiter, in iodine deficiency. There will be learning disability in iodine deficiency. Now, steps of thyroid hormone biosynthesis. The first thing that will happen is iodine will be trapped by follicular cells. Where that iodine is needed. We need you. Hey, come. We need your help here. Iodine will diffuse to the apex of the cells after being trapped. The iodine is transported with the colloid. Oxidation of inorganic iodide by thyroid peroxidase will then follow. Then two molecules of diodotyrosin will form T4. Two molecules making four of diiodotyrosine with the T4. Or monoiodotyrosine with one diiodotyrosine. Like I said, the kids in grade 1 will tell you 2 plus 1 will be 3. Then the endocytosis will occur, where thyroglobulin will be taken into the follicular cells from the colloid, and T4 and T3 will be released into the circulatory system. Isn't that great? We could see now how iodine could form the major raw material in the production of T4 and T3 with the help of thyroglobulin. The tyrosine. Remember, anytime you come across tyrosine, we're talking about T4. So the tyrosine, that is T4. The rate of T4 production is about 80 to 100 microgram per day, all happening within the thyroid gland. T4 is degraded at the rate of 10% per day. 80% of T4 is deiodinated as 40% to T3 and 40% to reverse T3. The remaining 20% is conjugated with glucuronide and sulfate, deaminated and decarboxylated to form tetraiodothyroacetic acid, that is tetra, or clipped between the two rings. T4 to T3, meaning T4 will be converted to T3, but this is not going to happen inside the thyroid gland, okay? When it is all about thyroid gland synthesis, T4 is the main person, T3 is low, but when it comes to peripheral conversion and activities of the thyroid hormones, T4 is the main person, but we cannot say we don't know T4 anymore because there won't be T3 without T4. T3 is the biologically active form. T4 conversion to T3 in non-thyroid tissue is regulated. Great, because by the time we'll be dealing with thyrotoxicosis and thyroid storm, we will know that we don't need excess of T3. The process is catalyzed by T4-5 dehydrogenases or tyrosine 5 dehydrogenases, predominantly happening in the liver and the kidney. There are other parts of the body. Oh, okay, I'm getting there right now. The tyrosine 5 dehydrogenase type 2 is found in the brain, the pituitary gland, and the skin. Why type 1? That is tyrosine 5 dehydrogenase type 1 is found in the liver, in the kidney, and thyroid. Type 1 dehydrogenase will be ineffective in fetus, in hypothyroidism, in anyone that is being stuck, in diabetes mellitus, in uremia, or someone on medication to deal with the thyroid hormones itself, propylthiouracil. This will be helpful in thyrotoxicosis, thyrostorm, and hypothyroidism. We'll get into that in another presentation. Still ineffective in amiodarone, glucocorticoids, beta blockers, reverse T3, all will be happening in the liver, kidney, and thyroid gland. Type 2 dehydrogenase will be inactive in fetus, hyperthyroidism, amiodarone, all happening in the brain, pituitary gland, and the skin. There are certain conditions where and when activities of both type 1 and 2 will be increased. And specifically, as per type 1, that will be increased in hypothyroidism, glucose used with insulin, and high-caloric foods, while the activities of type 2 will be increased in hypothyroidism. So, non-thyroidal illness and medications can affect T3 production. So you can now see that we are really getting down to the root of hypothyroidism. You see now that all these things can affect T3 production because the effect of T3 in the body, the biologically active thyroid hormone, is what is dictating to any human being that you have hypothyroidism or hypothyroidism. So all these things could lead to effects on T3 production. Both T4 and T3 are bound to tyrosine binding globulin, transthyretin, and albumin. They form the circulating storage pool, while the unbound is free for reuptake. T3 occupies specific nuclear receptors with B1 in the brain, the heart, liver, and kidney, while B2 is found in pituitary and hypothalamus. T4, T3 production regulation, because later on we'll be saying, oh, we want to make diagnosis, we will do thyroid function test, TSH, T4, T3, blah, blah, blah. What is the importance? Let's get down to the root. The thyroid stimulating hormone is from the pituitary, or the thyrotropin that is from hypothalamus will regulate the thyroidal biosynthesis of T4 and T3. When somebody is carrying load and the load is, if they are carrying it on their head in some parts of the world and the load is bending, and then you are saying, no, your neck is bending, it might be the bones that are actually bending, bow legs. So look up and down before making judgment. Thyroid stimulating hormone secretion is suppressed when there is a high level of T4 and T3. Extrathyroidal conversion of T4 to T3 will be affected by some other factors as well, like nutrition, certain hormones, illness-related factors, and many medications. Thyroid stimulating hormone secretion. Thyroid stimulating hormone secretion is stimulated by another hormone, that is thyrotropin releasing hormone. It means there's a master controller somewhere sending the boys around to carry out certain actions. So the thyroid-stimulating hormone secretion is stimulated by thyrotropin-releasing hormone, but can be inhibited by somatostatin, dopamine, and glucocorticoids. Now we have our thyroid-stimulating hormone, and it's pretty active, not inhibited. So what will happen? It will stimulate all the steps in thyroid hormone synthesis and secretion. It also stimulates intermediary metabolism, stimulates expression of many genes in thyroid tissue, causes thyroid hyperplasia, thyroid hypertrophy. How will TSH start working? It won't just start working just like that. Its actions will be initiated by binding to specific plasma membrane receptors. It will initiate activity of adenine cyclase, increasing cyclic adenosine monophosphate. The cyclic adenosine monophosphate will activate several protein kinases. It stimulates phospholipase C activity in thyroid tissue, increases intracellular calcium ion concentration, and protein kinase C activity. Thyroid hormones actions. Now we're seeing how the thyroid hormones are being secreted. We're seeing thyroid stimulating hormone, and then we're seeing T3, T4, how T4 is being converted to T3, and so on. Now, what are they going to do? We will start the journey from where it's supposed to start from, the neuroendocrine system. We have hypothalamic pituitary thyroid axis, hypothalamic pituitary adrenal axis, hypothalamic pituitary gonadal axis. Today, we'll be limiting ourselves to hypothalamic pituitary thyroid axis. So we'll talk about hypothalamus, we'll talk about pituitary gland, and we'll talk about thyroid gland. They are interconnected. That is why the production of thyroid hormones is highly regulated. So the hypothalamus, from elementary biology, that's in the brain. The pituitary, but this time around, we'll be paying attention to the arterial pituitary. We know there are other hormones, like just two of them, oxytocin and antidiuretic hormones produced at the posterior pituitary. That's why the two of them are related to diuresis, okay? The thyroid gland, that's what we're dealing with thyroid axis. The adrenal gland is the adrenal axis, while the gonads will be the gonadal axis. Now, hypothalamic pituitary thyroid axis. The hypothalamus will sense a drop in T3 and T4. And what will happen? The hypothalamus will initiate action. Thyrotropin releasing hormone will be released. Then the thyrotropin releasing hormone will stimulate the pituitary. Remember, we'll be dealing with anterior pituitary that will then do something that will lead to production of thyroid stimulating hormone. The thyroid stimulating hormone will not just be sitting down there, must do something that will stimulate the thyroid gland. Now we are inside the thyroid gland. The thyroid gland will then start to be producing T4 and T3 until the brain can sense that things are normal, that is, the thyroid state is reached. Thyroid hormones are very critical in certain situations. Well, let me say in almost all metabolic processes. They are critical in brain development in infants and young children, in somatic development in infants and early years of life, and in metabolic activities in everyone. Functions of all organs are affected by thyroid gland. By the time we get to signs and symptoms of hypothyroidism and hyperthyroidism, you will understand better. Actions of T3 are dependent on what? They are dependent on the availability of the T3 or T4 that will be converted to T3. They're dependent on thyroid hormone nuclear receptors and receptors cofactors, and of course, DNA regulatory elements. Somebody is asking, why did you bother me going through this one with your long, lengthy presentation? By the time we get to signs and symptoms of hypothyroidism, you will see the reason that don't just take one aspect of the problem and think you are going to solve it. Let's go through everything that can affect how this T3 will function, because it is the T3 that is not functioning well. That's why you have the signs and symptoms that we'll address in a bit. Thyroid hormones will promote glucose uptake. So they promote glucose uptake, and if there's reduction in function of thyroid hormones, that is T3, that may lead to type 2 diabetes mellitus. So it is fair to say that hypothyroidism could be related to type 2 diabetes mellitus. Interference with thyroid hormones can be from what? From retinoids and resinoids that can suppress thyroid-stimulating hormone, leading to central hypothyroidism. Smoking cigarettes. Polychlorinated biphenyls can interfere with thyroid action. Perchlorate, that is contaminants of water and food in some places, can lead to hypothyroidism. Thiocyanate found in water and cigarette can also interfere with what? With thyroid hormones, synthesis and function. Soya or isoflavones. Soya protein can interfere with T4 absorption from the intestine. I will not waste your time here. I will still deal with this in details in a bit. Right here. Yes, right here today. So congenital hypothyroidism in a child, and the child is receiving appropriate treatment with T4. They're taking it per oral, but unfortunately, the child is on formula feed that is soya based. You know what? The doctor, the parents, and that child will not win. They will not win. The hypothyroidism will persist. Don't worry, I will get into details of that later on. If you are not going to take anything out today, if this is the only thing you want to take, please take it. You can improve the life of that little man or woman that will become great later on when you take formula feed containing soya out when there's congenital hypothyroidism and you are giving your correct medication, which is T4. Don't worry, more on a bit. T3. T3 increases sex hormone binding globulin. Osteocalcin will increase. It increases concentration of angiotensin converting enzyme and decreases serum cholesterol level. That's great, right? T3 could be used as selective thyroid hormone analogs. The clinical application. So T3 is used as novel therapies for a variety of conditions like hypercholesterolemia. Remember, we just said decreases serum cholesterol, right? Hepatic steatosis, obesity, heart failure, neurological disorders. Okay, TSH stimulates. Somebody is saying, I've seen this before. Yeah, it's true. But remember, we're going through thyroid hormones actions, okay? What it stimulates, intermediary expression of many genes, causes thyroid pleasure hypertrophy. Now, action initiated by binding to specific plasma membrane receptors. That will initiate the activity of adenine cyclase, increasing cyclic AMP, and cyclic adenosine monophosphate will activate several protein kinases for glycogen, sugar, and lipid metabolism. So when we said that thyroid hormones will help or be involved in whole body metabolic process. You can see glycogen, sugar, lipid metabolism, stimulates phospholipid C activity in thyroid tissue, increases intracellular calcium ion concentration and protein kinase C activity. So we're ending the action right now, and then we'll move on. Now, hypothyroidism symptoms. Well, this is what many people will be looking for, on account of which they'll start browsing, and then they stumble on my presentation. But they've seen that my presentation is pretty long. You can see the journey before we will reach the symptoms right now. Okay, let's go through the symptoms, but while you are going through the symptoms, you will remember that something is responsible, then you'll be able to flash back on what could be. Now, where is the disease? Remember hypothalamic pituitary thyroiditis. So are we battling with problem with the hypothalamus? Is there trouble with pituitary? Is it the thyroid gland that is in trouble? We want to know. It can be at the level of the hypothalamus. So it can be hypothalamic pituitary disease or primary thyroid disease. So it can be hypothalamus, pituitary, or thyroid. Symptoms are determined by the rate of changes in thyroid stimulating hormone and T4 and T3, or the deficiency, and by how much. Let me explain this. So when somebody has hypothyroidism and you are picking symptoms, the symptoms will be, the severity of the symptoms will be the rate at which the thyroid hormones drop, okay? And how low it has reached, okay? When it is gradual, symptoms are less obvious. That is simple. It's clear enough to grade 3, I think. When the rate of changes is gradual, symptoms are less obvious because your body will keep adjusting along the way. And this is mostly in primary hypothyroidism. Don't bother me right now asking me what is primary hypothyroidism. I'll get to it in a bit. But symptoms are pronounced in acute states. And I've said this in many of my presentations that when people hear the word acute, they think it's less of a problem. When they hear the word chronic, they say, oh, it's horrible. And the reverse is the case. In medical field, we doctors and nurses were more concerned, and we are afraid when it is acute. But when it's chronic, we know your body is already adapting, adjusting, and fixing the problem one way or the other, but not curing it anyway. So, like sudden withdrawal of T4 or surgical excision of thyroid gland will lead us to acute states that will be very, very severe. Okay, problem in hypothalamic pituitary connection. In hypothalamic pituitary caused hypothyroidism, we will see the following. Other hormones will be deficient as well. Why that? Remember I said hypothalamic pituitary thyroid, hypothalamic pituitary adrenal, hypothalamic pituitary gonadal. So now that the problem is at the level of hypothalamus and pituitary, then it's going to affect the thyroid, it's going to affect the adrenal, it's going to affect the gonads, will affect all of them. B, like you will be battling with adrenal insufficiency at the same time that there is hypothyroidism. I think we are getting it now. Okay. Also, there will be hypogonadism. Remember, all the axes will be affected because the journey will start from hypothalamus. Now the hypothalamus is in trouble. In Graves' disease, When there's grave disease, and then you are treating the person, you have your metimaso, propita, uracil, radioiodination. Don't worry, we are not in hypothyroidism yet. That will change the course because they want the level of T3 to drop, and then there will be hypothyroidism. It's great, but your treatment is leading to hypothyroidism. So that may be vitiligo. Remember, vitiligo will be the dermatological sign that we are dealing with autoimmune condition. And when you find one autoimmune condition, you are likely going to find more autoimmune conditions. Of course, there will be ophthalmopathy. All other features of Graves' disease will be present, but then you are dealing with hypothyroidism. Not that Graves' disease is directly causing the hypothyroidism, but your treatment in Graves' disease. Accumulation of matrix substances. So accumulation of matrix substances will give you dry skin, hoarseness of voice, and edema. So you can now see that in hypothyroidism, you can have dry skin, hoarseness of voice, and edema. The signs of accumulation of matrix substances will be puffy face. This is what the patient will complain about, okay, the symptoms. I have dry skin. When I talk, of course, we'll hear it. Cannot talk much. And of course, I don't know whether they'll be able to tell that they have edema or not, but they will know they're swelling, okay? Then we will see the edema, we will see the puffy face, loss of eyebrows, periorbital edema, and an enlarged tongue. Enlarged tongue is what medical students will not likely forget. Enlarged tongue, hoarseness of voice, puffy face in hypothyroidism. Remember, there'll be loss of eyebrows, periorbital edema, and dry skin. In hypothalamic pituitary problem, we've said that not only the thyroid gland will suffer, hypothalamic pituitary adrenal axis will also be in jeopardy. So there'll be adrenal failure. And when there's adrenal failure, there'll be hyperpigmentation, yellowness of skin. Will all occur. So from hypothyroidism, you can see hyperpigmentation and yellow skin if it is caused from upstairs. Hypothalamus leading to pituitary. Hematologically, so the people in the hematological lab will be involved in hypothyroidism. Interesting. Oh yes, it is. There'll be a hypercoagulable state. Might be bleeding. Acquired von Willebrand disease, though not common. I have details on acquired von Willebrand disease already published. You can check my channel for that. Then will be anemia. In this case, it will be normochromic, normocystic anemia. And of course, megaloblastic anemia might be present. Remember, I've just said earlier that when you find one autoimmune disease, that's what we know in internal medicine. When there's one autoimmune disease, you look for other possible autoimmune diseases. In this case, megaloblastic anemia from pernicious anemia that is autoimmune, okay? Then iron deficiency anemia, why that? From bleeding. Now, women with hypothyroidism, menstrual cycle will be regular and it could be massive. And when that is the case, they lose iron, they have iron deficiency anemia. Cardiovascular system will not be spared in hypothyroidism. There may be mild hypertension from increasing peripheral vascular resistance. The cardiac output can drop. The heart rate can drop. As a matter of fact, hypo, low. Hello, ladies and gentlemen. There's an announcement right now. Everything about them will likely drop, except few factors like hypercoagulable states, Yeah. That will rise. Heart rate will drop. Cardiac output will drop. Contractility of the heart will drop. The heart function will drop. Diastolic hypertension, pericardial effusions, hypercholesterolemia, and hyperhomocystinemia. These ones will rise. They are not good anyways. Respiratory system will not be spared. It can have shortness of breath. When somebody is having heart failure with pulmonary congestion, what I'm talking about, there's backflow to the lungs, autopnea, paroxysmal nausea, dyspnea, pleural effusion, even rhinitis. Respiratory muscles weakness will lead to hypoventilation. Because remember, we said everything will drop. So activities is going to drop. They become sluggish. You just sit down there and just be watching. Okay. Can have sleep apnea in some like that because of increased tongue size. So particularly when they lay, supine, when they lay on their back, the tongue, at the back that is already big. Remember, we've gone through a large tongue initially. That could lead to sleep apnea. And when there is obstructive sleep apnea, you know what you are, applying for. You're applying for sudden trouble, hypertension, heart attack. Gastrointestinal tract. What will happen? Somebody has hypothyroidism. And then what has that got to do with gastrointestinal tract? It has a lot, my friend. That can be constipation. Decreased taste sensation. Oh, this will likely cause trouble in some families where, culturally, the man won't cook, the wife will be the only one who cooks, and then the how do I put it right now? What promotes unity and love in the family is the good food that the woman presents to the husband. Unfortunately, with hypothyroidism, sense of taste will be lost. Celiac disease, non-alcoholic fatty liver disease, ascites, and increased weight. How will one not gain weight? Everything is low. No activity has dropped. Tongue size is large. Edema everywhere. Ascites everywhere. High level of fat, and you are saying weight has increased. Okay, I agree. Weight increase, weight gain. Renal system. So the kidney will also suffer in hypothyroidism. Yes, there will be increased urea. So hyperuricemia. Reproductive system. Oh, yes, the other time I have said it that the problem we are dealing with now is hypothalamic pituitary failure. Then the gonadal axis is now suffering. So a young lady with this will have amenorrhea or oligoamenorrhea or hypermenorrhea with menorrhagia. Majority will have normal cycle. They may be down with infertility or early abortion if at all they are fortunate to have pregnancy. Hyperprolactinemia or galacturia can occur, and when this is the case, hyperprolactinemia and galacturia, there will be infertility because there will be negative feedback. Decreased libido. Oh, I pray they are not newly married. Erectile dysfunction. Well, unfortunately, it might not be two of them at the same time, but nobody prays for it. But if the woman is having decreased libido because of hypothyroidism, if the guy is also having erectile dysfunction because of hypothyroidism, then the equation is equal. Menorrhagia, pubertal delay. You see, this is a serious matter, so we need to get down to the root and get this treated, okay? Imagine a young lady dealing with hypothyroidism and then having the hope of one day getting married, raising our own family. With this, with all this, we better get down to the root. Now, Hashimoto's encephalopathy. When there is serious hypothyroidism, the brain is not left untouched. So that there's likelihood of Hashimoto's encephalopathy. This is encephalopathy in the face of autoimmune thyroiditis. That has a separate presentation. I will not even delve into that right now. Mesodermal coma. And somebody is asking me, do you mean one can become comatose from hypothyroidism? Of course, you can. Okay, so mesodermal coma is a severe form of hypothyroidism that is complicated by trauma, infections, cold exposure, opiates, and hypnosis. What are the clinical features of mesodermal coma? Hypercapnic, hypothermic, comatose, hyponatremic. There is more on mesodermal coma on my channel here. Please check it out. Musculoskeletal system. So the muscles, the hands are not left out. No, they are not. There can be carpal tunnel syndrome. Carpal tunnel syndrome comes in the body, body pain, joint pain, nails become brittle from hypothyroidism. And of course, the psychiatry ward will also feel the impact of hypothyroidism. The individual involved can have depression. The central nervous system. They can have decreasing hearing, paresthesia, sluggishness. It's not their fault. You've seen a young woman, middle age, with hypothyroidism at work, everything is slow. The woman is dealing with high-speed internet, yet can't work, at that pace. It's not her fault. It's not her fault, please. It's the thyroid. And of course, learning disability in children, you see some kids, 2 plus 2 is equal to take them 2 minutes to tell you it is 4. It's not their fault, find out. Just do thyroid stimulating hormone T4, T3, know what is going on. It can be hypothyroidism. And then the same child is having constipation all the time. Everything is slow. Then you check the pulse. The pulse of a child normally is supposed to be pretty fast, but it's slow. Oh, jeez. Do just the simple thing. Thyroid stimulating hormone T3, T4. Rule hypothyroidism out first. Metabolic processes. Fatigue, weakness, cold intolerance. Yes, this is what my friend has been looking for. Hypothyroidism, when we were in medical school, cold intolerance. In fact, part of the issue we always take, do you feel excessively hot or excessively cold? That's first thing we ask to rule out thyroid-related problem, right? Okay, you have it now, cold intolerance. But you've seen everything we've gone through before reaching here. Oh, it's more than that, cold intolerance. Dyspnea on exertion. Weight gain. How many times are we going to see this weight gain? Mental retardation, common in infants because the brain is still growing and thyroid gland is helping them. Cognitive dysfunction, growth failure. Oh, well, it's a good thing now in many parts of the world that checking for hypothyroidism at birth is a routine. Thanks to those government, the health authorities that will approve that. If that is not done in your zone, after this presentation, grab your computer or your pen, write letter to those who are governing you. There must be routine check for hypothyroidism in all the newborn human beings. Signs of metabolic process: slow speech or desired trait. It is constitution. It's not their fault. Some would think, oh, they are drunk. They are not. Okay, I say the alcohol level, do toxicological screening and so what? Do it. And you've done it, it comes as normal. You better check for the thyroid function. Delayed tendon reflexes, okay? You are doing your neuro. Bradycardia, we've seen that before. Carotinemia, we'll talk about that before. Pharmacology, somebody say, so hypothyroidism will affect medication. Yes, it will. Drug clearance is generally decreased in hypothyroidism. Let me explain this. It's just one point, but a very serious one. When drug clearance is decreased, it means the effect of that drug will be prolonged. So be careful when you have given somebody medication and you don't know the capability of the thyroid gland. The person is hypothyroid, is now on a very serious medication, and you are giving that medication repeatedly, maybe every 8 hours, every 6 hours, and so on, and the medication is accumulating, and then you will see the effect or the side effects or toxicity of that medication very soon, all from hypothyroidism. Ladies and gentlemen, you can see, you click on this channel, probably you wanted to read about cold intolerance, big tongue. It is more than that. And we're not done yet. But this is the end of signs and symptoms. We have more to talk about. Let's go. Another buster. Mesothelioma. The other time I said I will talk less about it because I will have the chance to talk more about it. Now you don't need to Google separately. Let's go. This is the buster for mesothelioma. Now mesothelioma coma. That's what we need to be, right? Okay. Mesothelioma is a severe form of hypothyroidism leading to decreased function of many organs. It is a medical emergency. If we can't remember anything under hypothyroidism that could be scary, let me scare you that mesothelioma is scary. It is a medical emergency. Why that? Mortality is pretty high. About 50% of people with mesothelioma coma will actually die. Wow, it's a serious matter. We need to take it as such. Why would they die? Sepsis, hypothermia, heart-related complications, kidney will shut down, respiratory system, the lungs, the bronchi, all will shut down. The central nervous system, the brain, the spinal cord, all will be involved. Well, there's light at the end of the tunnel. And where have you seen the light? Let me show you. It is rare. It is rare nowadays. Oh, great. Why is it so rare? Well, maybe in some parts of the world records are not being kept. But largely, people are taking the issue of hypothyroidism very seriously. Once the diagnosis is made, appropriate treatment is instituted quickly. If it is autoimmune related, they handle that. We'll go into it in a bit. If it is non-autoimmune and T4 conservate the situation, they give it quickly. So they don't get to very severe hypothyroidism, known as mesothelioma, and then become comatose, known as mesothelioma co. So it is rare nowadays. What are the clinical features of mesothelioma? Hypotension. Everything will drop. Let's see how many things will drop. The blood pressure will drop, the heart rate will drop, the sugar level will drop, the temperature will drop. Oh, what? The level of sodium will drop, hyponatremia. There's sepsis. The level of consciousness will also drop. Even activity will drop. The person become comatose. And what else could drop? I don't want to say it. But can you see it? Can you see what is there? The life can drop. Death. How can we make diagnosis of mesothelioma? Thyroid function tests. If it is primary hypothyroidism, we will see thyroid stimulating hormone rising. Somebody asked at the clinic one day that, a 19 person, college degree holder, I mean, in North America, that's what we're saying. In other parts of the world, you say university graduate. So, was asking, when you say I have hypothyroidism, how come you have said TSH will be increased? It's like you are in trouble and you have military cantonment, you will recruit more soldiers, right, to help you. That's the way. T4 is decreased. I will tell you later on why T4 level is pretty significant. In fact, more important to go for the value of T4 than T3 in thyroid hormone troubles. That is primary. TSH will be increased, T4 will drop. In central hypothyroidism, TSH will be normal, likely be normal or decreased. T4 will be decreased. Cortisol level must be acid to find out what is happening as per sepsis and adrenal insufficiency. Still on diagnosis, we'll have electrolyte. Remember they said hyponatremia already? So we want to see what's happening to potassium, calcium, magnesium, because when these ones drop, then we will run into what is called tozadipine. Tozadipine can degenerate to ventricular arrhythmia. First of all, the monomorphic ventricular tachycardia, then going down the hill to ventricular fibrillation from polymorphic ventricular tachycardia, and then down the hill to systole. If no advanced cardiac life support is system, then death. Complete blood count will see anemia, blood microscopic culture and sensitivity to sepsis, urine microscopic culture and sensitivity to sepsis, procalcitonin level. There you go. Somebody is asking me, what? This dog, are you crazy or something? What's the business with procalcitonin and the mesothelioma coma? We want to know, with the level of calcitonin, we'll be able to predict if this is bacterial related or viral related. Not necessarily telling us the type of bacteria, no. And also, when you have started giving your antibiotics, it will tell us whether we are winning or we are not winning. There is a separate presentation on procalcitonin alone already published by me. So check my channel for that. It's a good thing if you belong to my channel. I have a lot of helpful medical stuff already published out there. I've been doing this for more than 2 years. Brain arterial peptide probe. No, you see, heart failure. You know what I'm talking about. Blood urea nitric creatinine renal. Liver function test, liver enzyme. There are two different things. Liver function test and liver enzymes. Bleeding time, APTT, just hypercoagulable state we want to know. Blood glucose, I would deal with hypoglycemia and quickly help because hypoglycemia will kill fast. Toxicological screening, because by the time there's decreased level of consciousness, you want to know, is this something else somewhere? Now, how do we treat mesenchymal coma? Admit fast, not in the ward, admit into intensive care unit. As if intensive care unit is not a ward. It's just a separate ward, advanced ward for intensive attention. Then check airway, any secretion, any foreign body, sunshine is appropriate, and make sure the airway is patent. Then the breathing, what is happening, what is the respiratory rate, any breath sounds decrease or not, because there will be hypoventilation. All the muscles are weak. So breathing, respiratory rate, central cyanosis, peripheral cyanosis, trachea deviated or not, any, obvious chest deformity. Then we move to circulation. What's happening to the vital signs? Please, nurse. No, you won't hear like that. They won't like you. Just, excuse me, nurse. What are the vital signs right now? And I say, okay. Nice doctor. Then they'll supply. So don't hear. Okay. I was yelling because I felt concerned. So pause. Add sounds. You auscultate murmur, fluid in and out, capillary refill, pulse catheter, bladder catheterization, cardiac machines, hooked up, IV lines, 2 of them, ETT plus cardiac monitoring, Foley's hydrocortisone, 100 milligram every 8 hours for 2 days, levothyroxine, 300 microgram intravenously start. This is not the time. Who is going even to take it? This patient is in coma and can't take levothyroxine per hour from you. Then intravenous dextrose. But please, before you jab the dextrose, know the value of dextrose. The fact that I've just said it that it's going to give hypoglycemia doesn't mean you then give glucose to somebody that is already type 1 diabetes or autoimmune. Autoimmune can lead to all this trouble. And then the autoimmune has destroyed the pancreas. It's already having type 1. The glucose is up there, and you jar with glucose. And I say, oh, I listened to Dr. Toda presentation. No. Disclaimer. I'm now telling you, measure the glucose level first, please. Daily dose of levothyroxine, 50 to 100 microgram intravenously. And triiodothyronine, 10 microgram intravenously start, then 2.5 microgram every 8 hours. You can then rule out adrenal insufficiency and also rule out sepsis with cortisol level. Get mucosal precaution and sensitivity, get procalcitonin. Okay. Physical examination of cardiovascular system, and then you give glucose and so on, and then vasopressors. Intravenous antibiotics empirically, EKG or cardiac monitoring, rewarming or blanket, or bed, hugger, in case of hypothermia. Correct hyponatremia and other electrolytes anomalies. Multidisciplinary approach will help. Of course, they can't even allow you alone to be, an island, okay? Emergency room, physicians, intensive care unit, doctors, and nurses. Endocrinologists, yes. No, at this point, better send a consult fast. Many other people may be involved, as the case is. This is not the end of the presentation. That is the end of mesodermal coma. Now, subclinical hypothyroidism. Here it is interesting because I have decided to bring out debate on the treatment of hypothyroidism. I debated myself. I know figuratively divided myself into two human beings, one side for, one side against. Subclinical hypothyroidism. This has generated a lot of controversies in some quarters. But you are here today. Let's go. It's a nice Boston. See, it's snowing here at this Boston. Okay, subclinical hypothyroidism. Here you are going to find increased TSH with normal T4. The symptoms will not be so critical, will not be so exact, it will be vague. And the symptoms will be non-specific. So that's why we call it subclinical. So, no clinical diagnosis here. The diagnosis is limited to the laboratory results only, giving us increased TSH. It is about 4 to 15% in prevalence. Okay, subclinical hypothyroidism phenomenon is higher in females, and it will increase as the age increases. It's lower in blacks, but more in regions without insufficiency like Europe, with 4% in iodine deficient places and 24% in iodine sufficient places. I think the reason is that the iodine sufficiency has helped the thyroid gland from going down the hill to full-blown hypothyroidism. Causes of subclinical hypothyroidism: thyroid-stimulating hormone receptor gene mutations, autoimmune thyroiditis, subacute thyroiditis, postpartum thyroiditis, painless thyroiditis, partial thyroidectomy, radioactive iodine therapy, and radiation to the neck or head region. Still on causes, iodine-containing medications are amiodarone and those impairing thyroid function. You can see, when we're saying drugs or medications can cause hypothyroidism, we've been able to break it down into two different categories here. A drug is containing iodine on its own, as amiodarone, while a set of other drugs, like drugs in North America means street drugs, the medications prescribed are called medications, but in Europe, drugs are what you take for treatment, and street drugs are called street drugs. Those impairing thyroid functions will be lithium, cytokines, ethionamide, sulfonamides, and sulfonylureas. Still on causes of subclinical hypothyroidism, there could be inadequate replacement in the face of hypothyroidism. Okay, let's address this together. Somebody is having hypothyroidism, right? And supposed to be on levothyroxine, but the appropriate dosage is not being prescribed. So the person is not really getting down and down too much with hypothyroidism, but he or she is not getting out. So it's a clinical hypothyroidism. Increasing T4 clearance could be another problem. You remember, T4 is what will be converted to T3. So if the person is taking phenobarbital, and phenobarbital is sending T4 out, clearing it off, because of hepatic enzyme induction by phenobarbital, and then there will be less effect of the T4. That will be hypothyroidism, and might be subclinical because some will still be there. Malabsorption of T4, maybe because the person is taking soya whatever with the T4 while taking the T4 per oral. So that could be the problem. Thyroid infiltration with amyloid and hemochromatosis. There's a representation on hemochromatosis already published by me. acquired immune deficiency syndrome, and environmental toxins all could cause subclinical hypothyroidism. Yes, the clinical features. TSH less than 10 mU per liter may be asymptomatic. Some have symptoms that are not classical hypothyroidism symptoms. Cognitive impairment in older people might be the presentation. Some can come down with depression, while some will have decreased activities of daily living or instrumental activities of daily living, and then you'll be reading out depression and dementia. Some will have fatigue, and others will have constipation. All the above could be caused by some other medical condition. That is why we say the symptoms that the individual will present with will be non-specific. How can we make the diagnosis here? Once TSH is high and T4 is normal, then we are getting to subclinical hypothyroidism zone. We will repeat the test after 3 months. While that, TSH can be transiently raised. So when TSH is raised and T4 is normal, don't label this person to be, a member of subclinical hypothyroidism patients. No. Wait 3 months because it can be transiently raised. In pregnant women or women that are undergoing infertility evaluation or women taking fertility treatment, we should repeat TSH and T4 immediately in A to C and give T4 for treatment if TSH is increasing. Let me explain. The woman before us is a pregnant woman, or the woman is undergoing infertility investigations, or she's already taking treatment for infertility, then we will not wait for 3 months like the other general population. We will repeat the TSH and T4 immediately if the woman belongs to any of these. And if the value is still high, TSH is still high, then we'll start T4, levothyroxine. What are the possible differential diagnoses of subclinical hypothyroidism? It might be that the individual is at the recovery phase from non-thyroidal illness, because that can transiently increase the thyroid stimulating hormone. So, adequate history here. It might be hypothyroidism that is as a result of hypothyroid phases of acute painless or postpartum thyroiditis. This will be a transient problem as well. Then it might be a problem that is not the patient problem, but the problem of the lab people. They are good people, but they are human beings. It might be assay variability that may be the factor, like lab error. And heterophilic antibodies can alter thyroid stimulating hormone measurement. So we should put all this in mind while interpreting those values. Still on differential diagnosis, rheumatoid factors can interfere with thyroid stimulating hormone acting as heterophile antibodies, that is in autoimmune conditions. Untreated adrenal insufficiency may lead us to that. Autoantibodies to thyroid stimulating hormone might be the reason why TSH is raised. Thyroid stimulating hormone producing pituitary adenoma is a possibility. So, what is happening to the pituitary gland itself? Still on differential diagnosis, the reason why we need to go through all these differential diagnoses is because we just don't want to be jabbing that person with levothyroxine. All medications have side effects. In those days when we were in medical school, we said, okay, all medications will have side effects except vitamin C. Now we know that that's not completely true. Even vitamin C will have side effects at certain dosage. It might be resistance to thyroid hormone, might be central hypothyroidism with mildly increasing TSH of 10 milli-unit per liter and a low or low normal free T4. Might be as a result of morbid obesity. Please look at the weight. You don't even need to weigh a person. No, by mere looking, you know. Where leptin mediates ITSH and TSH falls with weight loss or bariatric surgery. Now, debate on treatment of subclinical hypothyroidism. Pretty interesting. You cannot see this in any literature. I drafted it. And you can leave your comment after listening to it, whether I was thinking right or I was off the track. No, but I think I was thinking right. Okay, let's see. Now, we'll take history of medications, and it might be secondary to Hashimoto's thyroiditis. So we want to debate whether or not we will treat, because I've seen some of my colleagues saying I will not treat, others will say I will treat. Then I've decided to do this. So to those who will treat, that is, they are for treating is red. To those who will not treat is green. So let's go. Okay, if not treated, what will happen? But I want you to get this clearly. Normally, post-surgery, there's likelihood of persistence of clinical hypothyroidism. So some will say there's no reason to treat. So reason against treatment, because that's a normal phenomenon, right? Okay. There's likelihood of spontaneous recovery. So to those who have said, I will not treat, so that's the reason for them not treating, because the likelihood of recovering spontaneously is there. But to those who we treat, they will argue that from subclinical hypothyroidism, it can progress to overt hypothyroidism. That is a full-blown hypothyroidism in about 30 to 40% of the cases. Then who will know? The patient that will belong to the 30 to 40% that will then come down with overt or full-blown hypothyroidism. And remember, the overt or full-blown hypothyroidism can go down the hill to mesodermal coma and they will die. Okay, if not treated, what will happen is likely going to increase cardiovascular diseases. So reason why some people will treat that, I don't want the complications of hypothyroidism. For example, there may be increased rate of coronary artery disease. So heart failure, stroke, dyslipidemia will all be there. So they want to treat and have peace of mind, right? So if you don't treat, there may be decreased fertility in women who will be down with oligomenorrhea, and some will be completely off the menses, that is full amenorrhea. So you don't want that woman to end up that way, so you want to treat. Non-alcoholic fatty liver disease might be another complication, and you don't want that, so you want to treat. Neuropsychiatric symptoms might come up, and then you don't want that, so you want to treat. So the total is 7 cases, and then those who don't want to treat, we have positive argument as 2 out of 7, which will be 29%, and those who want to treat, based on the point I was able to gather, will have 5 out of 7, that is 71%, or ratio 3 to 7, against and for, respectively. So 3 to 7 as the ratio. So it is better to treat. That is the conclusion from our end. In conclusion, if TSH is greater than 10 milli-units per liter, then treat with T4 to prevent progression into overt hypothyroidism. If the value is between 4.5 and 10, discuss with your team because a tree cannot make a forest. If the value is between 7 to 9, you can treat if you are dealing with a younger patient or the individual is under 65. So we must consider the age and thyroid-stimulating hormone level if no symptoms or the symptoms are subclinical. You can use the lowest dose of T4. Whether you want to prevent thyroid toxicosis, and of course, you keep monitoring. Yeah, now we are now at another bus stop. That is causes and diagnosis of hypothyroidism. Okay, you're tired, maybe you can pause, have your coffee, snacks, and then come back again. Okay, you're back. Okay, let's go. Central hypothalamic pituitary disorder can be a cause. Okay, in that case, thyroid releasing hormone deficiency will be the problem, leading to thyroid stimulating hormone deficiency because signal will not come from hypothalamus to pituitary. So when TRH is down, TSH will follow. Hormone resistance. Generalized thyroid hormone resistance could be the problem. If it is not hypothalamic problem, it's not hormone resistance, then it could be autoimmune. If it's autoimmune related, then we'll be dealing with Hashimoto's thyroiditis. With chronic autoimmune thyroiditis, already have published a several presentation on Hashimoto's thyroiditis, including Hashimoto's encephalopathy. Although I will go through that right here, but if you don't want to wait till then, you can click on Hashimoto's thyroiditis on my channel and you get full info. Hashimoto's thyroiditis. The name is pretty interesting, Hashimoto's thyroiditis. This is the link to the full presentation on Hashimoto's thyroiditis already published by me. So Hashimoto's thyroiditis could be under the name that we all knew it to be, or some will call it Hashimoto's disease, others will call it chronic lymphocytic thyroiditis, or others will summarize it to be autoimmune thyroiditis. Any of this is all about one condition, Hashimoto's thyroiditis. The story of hypothyroidism is incomplete without that of Hashimoto's thyroiditis. It is the common cause of hypothyroidism in the Western world or in iodine-sufficient countries. Women to men will be 8-to-1 in ratio, meaning more women will be affected than men. Ashy, because you call me lazy? Not quite. We like to abbreviate names a lot. So, Hashimoto's have been shortened by me to Ashi, can have the following. Gradual loss of the thyroid function with goiter or without goiter. There is apoptosis of the thyroid gland epithelial cells, and it is closely related to Graves' disease, or one can evolve to the other, meaning Graves' disease can evolve to Hashimoto's, Hashimoto's can evolve to Graves' disease. Remember, Graves is also an autoimmune condition, and I've said it times without number in the last 2 years plus that when there is one autoimmune condition, we then look for other autoimmune conditions. It has many phenotypical presentations. It can also be with hypothyroidism or without hypothyroidism, with goiter or without goiter. When will it be without goiter? when there is atrophy of the thyroid gland itself. Remember, the autoimmune will go into the gland and destroy it, scoop it off, send the thyroid hormones into circulation initially, and then when there's no part of the thyroid gland tissue to deal with and scoop again, then the thyroid gland will shrink, and then there will be hypothyroidism. So serum thyroid autoantibodies presence is the proof, is the key that we are dealing with Hashimoto's thyroiditis. Serum thyroid autoantibodies. Ashi has risk factors. What are they? Genetic susceptibility is a very strong factor here. So it can run in the family, okay? Can run in the family. If your mom has it, then keep an eye on your own thyroid gland and be careful. Well, you cannot be too careful with autoimmune conditions because it can just be like that, but certain drugs can trigger autoimmune conditions anyways. Stress, reduce your stress. Pregnancy, well, you need to raise a family if you choose to have children. Just let your physician know, then you both work towards. I'll still talk more about pregnancy very soon and Hashimoto's. Fetal microchimerism, that is two genetically distinct cell populations in one individual. Iodine intake. Okay, here's a point. Somebody sent a question to me in the past, and let me just make this clearer again, that increased iodine will lead to increased Hashimoto's. Sex steroids, all these are associated risk factors, but we have more. Still on risk factors will be certain drugs, radiation, gender, more in women, viral infections, another autoimmune disease. Remember, Graves' disease can evolve to Hashimoto's. Hashimoto's can evolve to Graves'. Then age, any age, because it's found in children. The mechanism. There's molecular mimicry and bystander activation. Thyroid cell HLA expression, also known as chronic lymphocytic thyroiditis, often leading to atrophic gland and hypothyroidism. Middle-aged women mostly be affected, but can also occur in men and women of any age, including children. The clinical features of Hashimoto's will be mostly that of hypothyroidism. So, I will not waste your time. I know you are getting tired. This is a pretty long presentation and we're not done yet. So, just reverse back to the signs and symptoms of hypothyroidism already gone through. There may be goiter, might be painless. Subclinical hypothyroidism might be the case, or later on will become overt or full-blown hypothyroidism. With increasing destruction of the thyroid gland, it will shrink and the goiter will disappear. The goiter here will disappear when the thyroid gland shrinks with increasing destruction of the thyroid gland. Okay, Hashimoto's, I know because it's a long presentation, I have decided to put this link here for full info on Hashimoto's thyroiditis that will go through the diagnosis. But to those who have the time and want to grab it once and for all, I will quickly go through them without producing the slides. That if you want to make diagnosis of Hashimoto's thyroiditis, you start with thorough history and physical examination. You can have ultrasound of the neck done, and thyroid peroxidase antibodies will give you the clue. Then you can embark on thyroid function test. That means you want to have TSH, T4, T3 with or without TRH done. Then have your complete blood count, glucose, microscopic culture and sensitivity, renal function test, liver function test, and then have some uh, factors that will be pointed to autoimmune or not, like antinuclear antibody, rheumatoid factors, C-reactive protein, and erythrocyte sedimentation rate. So that is what we can do to make the diagnosis of Hashimoto's. Then for the treatment and warning, although I've written it here that avoid iodine or soya-rich diet while on T4, please do that. Let that warning go out, sound the alarm. When it comes to the treatment of Hashimoto's, the treatment is going to be for a pretty long time, that will span between 3 to 6 months. If asymptomatic, you can do nothing, but you keep monitoring. If there is hypothyroidism, then give your T4 with or without T3. Some physicians are now combining T3 to have faster and better outcome, and while some are saying T4 will actually be converted to T3 after all. So what's the point? Well, depends on the school of thought you belong to and what is obtainable in your jurisdiction. If this person is done with Hashimoto's encephalopathy, then don't worry, there will be next presentation or towards the end of this very long presentation, I will end it with Hashimoto's encephalopathy. So we will repeat our function test every 8 weeks. And then when we'll know that we are winning, we'll reduce the frequency and extend the time between repeat tests to every 6 months. So the warning is stated, and we come to the complications. When it comes to the complications, there might be increase in chances of coming down with mesenchymal coma. And there may be cardiomyopathy, heart failure, hyperlipidemia, depression, and increased ischemic heart disease. And now Hashimoto's and pregnancy is such that in pregnancy, hypothyroidism is due to Hashimoto's until otherwise proven. Let me explain what I meant by that. So if a pregnant woman who had not been having hypothyroidism before pregnancy suddenly comes down with pregnancy and hypothyroidism at the same time or close to the onset of the pregnancy, then that is Hashimoto's, thyroiditis until otherwise proven. And that can lead in that pregnant woman, that can lead to miscarriage or premature birth, stillbirth, preeclampsia, if it's not properly managed to full-blown eclampsia, then poor growth or impaired brain development in the newborn. So it's a serious condition that must be handled as such. Okay, so now soya and hypothyroidism. Somebody is asking me, what's the business with soya and hypothyroidism? Soya is just food that we can eat and then to make the milk or whatever. Don't worry. Just listen in a few minutes. This is a nice buster. Oh, I like this. Okay. I like that. Soya and hypothyroidism in children. Here is a link for full presentation because I don't want to weary you. But briefly, let me tell you that if there's congenital hypothyroidism, that will affect the brain and somatic growth. I bet you. Prompt treatment with T4, that is levothyroxine, is very, very necessary here. In fact, we are not just going to give T4, we'll give very high dose of T4, okay, like 10 to 16 microgram per kilogram per day. You may use lower dose if you are dealing with borderline hypothyroidism, but the use of soya and soya-containing formula feed can prevent absorption of the T4 from the gastrointestinal tract, specifically the intestine. Further details ahead. drugs like lithium, amiodarone, etonimide, interferon alpha, interleukin-2, tyrosine kinase inhibitor, the checkpoint inhibitors immunotherapy. Iatrogenic. We can cause hypothyroidism because we are helping, like thyroidectomy, radiation therapy, radioiodine therapy, Graves' disease or hypothyroidism that is taking treatment to lower the thyroid hormone level. All this could lead to hypothyroidism. Iodine. Iodine deficiency or excess could be the culprit. Congenital. Congenital hypothyroidism that may be as a result of thyroidogenesis or dysgenesis or defects in hormone synthesis. Withdrawal of thyroid hormone might be inadvertently, or I don't know, for many reasons why someone will suddenly stop taking the thyroid hormone, might be depression or dementia or abuse, then it can lead to hypothyroidism. Transient hypothyroidism can occur in thyroiditis. There's inflammation, and later on the inflammation will subside. In granulomatous thyroiditis, in postpartum thyroiditis, in subtotal thyroidectomy, and Graves that is receiving treatment with radioiodine therapy. We are now at another bus stop, but this bus stop is as important as the treatment itself, and that is how to make the accurate diagnosis of hypothyroidism. Because if we miss the diagnosis, then we will not institute the correct treatment, and without correct treatment, the individual having this problem will not get out of it. Without much ado, let's go. The journey to accurate treatment will start with accurate diagnosis, and accurate diagnosis will start with thorough, correct, appropriate history. The history of presenting illness, you can rewind back to signs and symptoms. We'll go through that. And then rewind back to causes of hypothyroidism. We'll try to rule any of the causes out. Then we'll delve into family history of thyroid diseases, medication history, even street drugs. Remember, we've come across amiodarone, we've come across lithium, amongst many other medications that could lead to hypothyroidism, right? This person might just be having mood disorder, and he or she is on lithium, and now we're battling with hypothyroidism. And somebody is saying, what's my business with hypothyroidism? And it's a psychiatry issue. Yes, it's a psychiatry issue, but the medication you are taking has led us to this. How about autoimmune diseases? Now, maybe this person is having type 1 or pernicious anemia or rheumatoid arthritis or systemic lupus erythematosus, and now we are worried that hypothyroidism is also here because Hashimoto's may be here, or it can even be Graves. Okay, and surgical history. Any surgery, along the neck region, we want to find out. Or even in some people, it might be that they've actually had surgery on thyroid gland, like thyroidectomy, either subtotal, partial, or whatever. Then pregnancy, we've seen that pregnancy and hypothyroidism may likely occur, particularly in the phase of Hashimoto's thyroiditis. Remember I said earlier that if there is no hypothyroidism before pregnancy and the woman has pregnancy and is now down with hypothyroidism, it is likely going to be Hashimoto thyroiditis until otherwise proven. And of course, menstrual history, because in anyone who is a woman of childbearing age, you want to be sure that she's not pregnant right now. Then we'll go to physical examination. When it comes to thyroid-related problems, we know what to look for, right? From hair down to the toe. the ear, the face, the tongue, the hand, cardiovascular system, neural system, the weight, the neck. For the thyroid, we know how to examine, we go to the back of the neck, the patient will have to swallow water, and then we'll see how the thyroid gland will move between our tongues, and we check the lymph nodes around the head and neck region. We will do all this, right? Puffy face, large tongue, we will check everything, sparse head and cardiovascular system, we'll check everything. Then we'll head to the lab. Specific laboratory investigations relating to hypothyroidism will involve thyroid function test, and then we'll start with the hypothalamus. Remember, hypothalamic pituitary thyroid axis, right? So TRH to know what's happening to the hypothalamus, TSH to know what is happening to the anterior pituitary, and T3, T4 to know what's happening with the thyroid gland itself. And of course, autoimmune, that could be our big issue here. We want to know about thyroid antibodies. Central problem. When there is central hypothyroidism, thyroid-stimulating hormone will be within normal range, can even be decreasing. Remember, it should be increasing, right? And T4 will definitely be low. Okay. Now, it might be a tertiary issue, meaning it is happening at the hypothalamic level. And what will be the indication for that? The value of thyrotropin releasing hormone will give us the clue that we are dealing with trouble at the hypothalamic level. It might be problem at the anterior pituitary level, and thyroid stimulating hormone will give us the clue about that. So we expect the thyroid stimulating hormone to be influencing the primary gland, which is the thyroid gland, and that will be showing us the evil happening in thyroid gland with the value of T4 and T3. So it depends on where the injury is. We know what to get as per that. Hypothalamus, TRH, pituitary, TSH. The thyroid gland itself, T4, T3. And when it is autoimmune, we'll get thyroid peroxidase antibodies. Now, the primary hypothyroidism. TSH will be increasing, T4 will be decreasing. Okay, if the problem is subclinical hypothyroidism, TSH will be increasing, T4 will be within normal range. Then we can then do general tests. When I say general tests, because it is not specific to thyroid gland. So complete blood count, blood sugar, liver function test, renal function test, lipid, urine, microscopy, culture and sensitivity, antinuclear antibody. Okay, we want to roll out autoimmune again. Erythrocyte segmentation rate, C-reactive protein von Willebrand factor. Then, radiological investigation might be embarked upon. We can have X-ray, neck, CT, CT of the head, EKG. We want to know what the complications are already in the heart, okay? And the ultrasound of the neck. So all this could be done. Now, thyroid function test. Yeah, somebody is already asking me that what's wrong with this guy? You want to make diagnosis of hypothyroidism or hyperthyroidism, and you will not lay more emphasis on thyroid function test? No, don't be in a haste. I won't do that. I'm not going to close this presentation without thorough justice to thyroid function test. So without much ado, we're now at an interesting bus stop when it comes to thyroid pathology, thyroid function test. Let's go. Okay, the lab values in thyroid function test. All will be examined will be about thyroid stimulating hormone, T4, T3. Now, normal value of TSH. We want to go through the normal value before we start comparing and contrasting, okay? For TSH, normal value will be between 0.4 to 4.0 milli international unit per liter. Treatment is expected to start when there is persistent elevation in serum thyroid-stimulating hormone greater than or equal to 10 milli international unit per liter. We will also treat an undetectable serum of thyroid-stimulating hormone less than 0.1 milli international unit per liter. Normal range for T4 and T3 will be that T3 normal range is between 100 to 200 nanogram per dl, okay, or 0.9 to 1.95 nanogram per mil. The T4 normal range will be 4.4 to 12.5 micrograms per dl. So we've seen the normal values, right? And then let's move on. Now, for antithyroid antibodies, the thyroid peroxidase antibody less than 35 international unit per mil will be the expected situation. We don't want it to be high. Thyroglobulin antibody less than 20 international unit per mil, while thyroid-stimulating immunoglobulin antibody less than 140% of basal activity will be the normal range. We've seen the values of normal range for all these tests, right? Okay, let's now make specific diagnosis. In euthyroid, meaning everything is fine. Everything is just within the expected value. TSH will be normal. T4 will be normal. T3 will be normal, meaning they will not go below or above that normal range. In euthyroid hyperthyroidism condition, something is different, okay? It's euthyroid, so TSH is normal, but hyperthyroidism is the issue now, so T4 will be normal or high, T3 will be normal or high. In euthyroid hypothyroidism, okay, TSH will remain normal, but T4 can be normal or low. Remember, it's hypo now. T3 will be normal or low. Remember, it is hypo. In euthyroid with T3 therapy, TSH will be normal because it's euthyroid, right? T4 will be low, while T3 will be normal or high. Remember, it's T3 therapy. You are giving T3 exogenously. In euthyroid with thyroid extract therapy, TSH will be normal, normal or low T4, normal or high T3. In primary hypothyroidism, TSH will be high, T4 will be low, T3 will be low or normal. The reason why it might be normal is it depends on when you take the sample. If the leftover from T4 has just been converted to T3, you can still find it normal. But if it has taken a while, when T4 has been depleted and nothing is being converted back to T3, it will be low T3 as well. But high TSH, low T4 will be enough to make the diagnosis of primary hypothyroidism. So clinical hypothyroidism, remember I've delved into this in details before now. You can rewind and get the detail again. There won't be signs and symptoms that will be so classical of hypothyroidism, but TSH will be high, giving us clue that there's hypothyroidism somewhere. T4 is still normal, T3 is still normal. That is why we are not picking so much signs and symptoms of hypothyroidism. The individual is not having activities of daily living, being altered. You understand what I'm saying? So it's subclinical. Now, in hyperthyroidism, and somebody is telling me, what's your business? We're talking about hypothyroidism, you are bringing hypothyroidism. Hey, pause. There's no need to fight. I'm just going through the thyroid function test in total, please. So in hypothyroidism, thyroid stimulating hormone will be low, T4 will be high or normal, T3 will be high. We are not dealing with hypothyroidism here. This is hyperthyroidism. You'll meet me again during hyperthyroidism presentation. In subclinical hyperthyroidism, okay, everything hyperthyroidism now, I will just skip through. TSH is low, T4 is normal, T3 is normal. No more explanation on that. Abnormal hypothalamic pituitary function. Okay, something is happening upstairs. So we will have TSH, T4, T3 level. TSH mediated hyperthyroidism will give us normal TSH or very high TSH. T4 will be high, T3 will be high. In central hyperthyroidism, I've said I will just be skipping stuff on hyperthyroidism. We'll meet when we have the next presentation on hyperthyroidism. But if you haven't subscribed to my channel, please kindly do. The effects of biotin. If someone says, hey, doc, what's the problem with biotin? I'm taking biotin and you can stop me from taking it. That has nothing to do with my neck problem. That has nothing to do with my thyroid gland. Okay, wait. We are right now at that very bus stop. Okay, let's park our car right now. Let's get down and we're going. Effects of biotin and vitamins on heart attack and thyroid hormones. Do you know why I'm bringing this up? We can misdiagnose thyroid problems just because the patient had taken biotin. Now, multivitamins, relationship with thyroid gland and heart attack. Vitamin H is otherwise known as biotin. Could be found in dietary supplements and also in multivitamins. Now, take this serious, please. Multivitamins are not street drugs. They are not drugs of addiction. You are free to take it if you want, and so on. It's over the counter, correct. But if you come to me and I need to have thyroid function test done on you, I will take the history of your consumption of biotin. Why that? Let's go. Biotin could be found in the following places. The multivitamins, B complex, coenzyme R, prenatal vitamins, vitamin B supplements, vitamin H, dietary supplements for hair, skin, and nail growth could be found here. Now, what would the effects of biotin be? It's likely going to lead us to falsely low troponin in heart attack. That's heart attack. I won't delve into that too much here. But when heart attack is misdiagnosed, death is at the door. Now, it can also affect parathyroid hormone, but my focus now is thyroid stimulating hormone, TSH, T4, T3, all could be affected, either falsely increased or falsely low. Bam. There we go. Did you see that? We've been saying accurate diagnosis, accurate treatment, patient is fine, patient will be going back to work. But because of one multivitamin or B complex containing biotin, we're going to get wrong values of TSH, T4, T3, and then we're in trouble. In thyroid gland, falsely high T4 is possible, falsely high T3, falsely low TSH. So it will be giving us a picture of hyperthyroidism when we are actually dealing with hypothyroidism. And if care is not taken, you're going to load this person with more hyperthyroid treatment agents like methimazole, propyl uracil, and even radiation will start. Then the doctor will be thinking of hyperthyroidism. Then radioiodination will start. You go and look for beta blockers, but the patient is not having no palpitation. He or she is not having constipation. He or she is not having, rapid pulse. So why you get beta blockers? You want to keep the beta blockers away because you could not pick the reason for beta blockers right now. So propyl uracil, methimazole, you want to give that. Do you know what's happening? You are shutting down the thyroid hormones the more. Or too much of levothyroxine in the treatment of hypothyroidism. If we get falsely high TSH, falsely low T3, falsely low T4. Okay, somebody is saying, Doc, but how are we going to get out of this problem? No, don't worry. That's why my channel has been put in place in the past 2 years plus. We just need to look for solution to all these problems that we've not envisaged before now. We must take thorough history about biotin or multivitamins intake in anyone that we want to have thyroid function test done on. Then we'll interpret that result cautiously if they've taken biotin or multivitamins before now. We can do more things. We can assay for the level of biotin itself in the serum. But if this is not even an acute emergency, why not delay the lab test till 2 days after the last biotin or vitamin must have been ingested? There you go. The problem is solved. Problem is solved. Just tell the young woman or the young man, I'll see you back. Today is Monday, okay? Wednesday, it'll be fine to see. But please don't take these vitamins again. The last one you took was on Sunday. Okay, fine. You'll be free on Monday. You'll be free on Tuesday. Then Wednesday, I will have the test done. Then you're done. So more history, more physical examination, and other investigatory tools if you are still confused. Like I said, if the value of TSH is low, T4 is high, T3 is high, and you are thinking of hyperthyroidism, but then this person is not having clinical signs and symptoms of hyperthyroidism, I won't give those propyl uracil, methimazole, or suggest radioiodination. I won't go that far because we are not treating the lab report. We are treating human beings. Okay, fast. Biotin is in vitamins, not a bad medication to be taken. It's available over the counter. The problem is about lab tests under certain situations. False troponin has led to wrong diagnosis and many people have died. Falsely increased T4, T3, and decreased TSH can lead to decreased treatment of hypothyroidism and even worsen hypothyroidism because we want to treat hypothyroidism. Wrong diagnosis of hypothyroidism when it is actually hypothyroidism is a possibility here. And then imagine what will happen to that person. What will happen? Oh, death. Now, at another bus stop, and it is all about soy and hypothyroidism. Somebody is saying, this guy would not stop amazing me. What is his business with soybean or soya bean? Depends on how you call it in your jurisdiction, your locality, okay? It might be soy, it might be soya, it might be soybean, it might be soybean, or whatever. Just know what I'm talking about. It has effects on hypothyroidism. It can worsen life for people with hypothyroidism. Okay, let's go. Congenital hypothyroidism is a big problem. At birth, kids are screened. So we will screen all the newborn for hypothyroidism, right? Okay. Hypothyroidism will interfere with normal brain growth and development. That is why we're screening. Will also interfere with somatic growth later in infancy or early childhood. So that's why we're screening. Okay, so what is the problem of soya in all this? Let's see. Prompt treatment is required when there's hypothyroidism and congenital hypothyroidism to be treated with levothyroxine powder promptly. As a matter of fact, you are not just going to give the levothyroxine, you are going to give a very high dose in children, 10 to 16 microgram per kilogram per day. You may choose lower dose like 8 to 12 microgram per day if the hypothyroidism is just at the borderline level. In congenital hypothyroidism, because we don't want the future of that child to be jeopardized because of our own failure today. So we'll be monitoring for the level of hormones like TSH, T3, T4, physical examination to monitor the effects of the treatment to prevent learning disability, poor growth, and brain development. Okay. If it is a transient form of congenital hypothyroidism, we will evaluate yearly, and that will be fine. Now, warning about soya or isoflavones. Soya protein can interfere with T4 absorption from the intestine. There you go. It can, you've made the correct diagnosis, right? And you really need to treat this. In fact, you are going for a very high dose. But something is happening. The mother is giving this child formula field that contains soya, and they are in trouble. It will prevent absorption of your good medication. You've made correct diagnosis, you've instituted good treatment, correct treatment, but it won't work. That formula filled with soya will not let T4 to be absorbed from the intestine. So congenital hypothyroidism receiving treatment should not have formula that is soya-based. Please, the company that is manufacturing soya formula feed, I'm not against you. I am not against you. In fact, I can campaign for it. Soya is a good source of protein for every human being. But for people with hypothyroidism, truth be told, it will interfere with absorption of T4. That is the only headache I have with soya. I like it. In conclusion, you've done well to have the correct diagnosis already made, but don't destroy your good work with the formula field. You are not the one giving the formula field to the uh, newborn. The mother who brought the child for treatment is not wicked to now give the formula feed. It's because she didn't know, and I should know, and I will tell you. Don't give formula feed with soya because I'm dealing with congenital hypothyroidism in this child. Why that? It won't let my T4 levothyroxine to help this child. It's a small piece of information, but vital. Thank you. Now, a big bus stop. Oh, so many vehicles will be parked here because we will enter into so many places, and I'm talking about treatment of hypothyroidism. Okay, let's get down quite very well because we're going to stay here for a while. Let's go. Who requires treatment? That's the first thing to ask ourselves. Because not everybody that will need our T4. And is it only T4 that we will need? Let's go. People that must be treated will include overt primary hypothyroidism. People with increased TSH with decreased T4 with or without symptoms. Remember the debate on subclinical hypothyroidism. Pause and go back. Still on who requires treatment, because it's not everybody that will be given T4. no treatment, even if there's increased TSH and decreased T4 in certain situations. Okay? Situations caused by drugs, you don't give T4 in that case. Even you are saying classical thyroid function test pointing to hypothyroidism, high TSH, low T4, you will still hold your T4. Why? You have discovered that the problem is exogenous, coming from outside. It's because the person is on certain drugs. Then what are you going to do with that drugs? Discontinue, but discuss with who has prescribed the drug. Okay, so that they can look for alternative. If it is lithium, carbamazepine could be used, but I'm not going to tell the psychiatrist that. The psychiatrist will figure that out. Discuss the following with an endocrinologist. If you are confused, grab the phone or send the letter, fax or whatever. Subclinical hypothyroidism, you don't want to know, or you just want to know where you need to belong. Painless thyroiditis and subacute thyroiditis. In congenital hypothyroidism, we will start treatment immediately as soon as the neonate has been screened. I think we remember who a neonate is. Any child that is delivered right now, hour 0 to 28 days is a neonate. And then in congenital hypothyroidism, we use very high dose of T4, levothyroxine. 10 to 16 microgram per kilogram is acceptable. Once TSH is high in children, treat until they are 2 years plus. Why? Somebody is saying, what's your business? Why will you fix number of years to treat these good human beings that have just come to this world? Within 2 years, the brain, the central nervous system is still forming, is still growing, still developing. It's not fully formed at birth, no. The first 2 years is critical for central nervous system formation. Thyroid function test should be done every month on the 3rd birthday and every 6 months after then. The goal of the therapy, what do we need to get? Why do we need to treat? What's our, what are we targeting? We want to relieve the symptoms, assuage, make situation better for this patient, alleviate, okay? Make TSH normal, okay? And then reduce the size of goiter, prevent over-treatment. We have to be careful. The fact that this is hypothyroidism and we are giving our T4 doesn't mean we should then overdo it and tilt the patient to thyrotoxicosis. Remember that the older we become, the higher the value of TSH in us. For example, in elderly man greater than 80, TSH 7.5 milli international unit per liter is regarded as normal. It's regarded as normal. So it's not everybody with high TSH that is having hypothyroidism. The older you become, the higher the value of TSH. Now, the treatment of hypothyroidism. Somebody is saying, oh my goodness, so you wasted our time going through all this before hitting on hypothyroidism. No, nothing is wasted. Okay, no. Check my channel for definition, clinical features diagnosis, and differential diagnosis of hypothyroidism. Just pause and flashback, okay? We use T4, that's levothyroxine. Some will combine T4 and T3, that is levothyronine. Leotris is going to combine both 3 and T4. If you are using T4 only, you can give between 12 microgram per day up to 250 microgram per day. Warning about combined T4 and T3. Combination is not encouraged, but I'm not saying it is disallowed. No, I'm not saying that. But it is okay in the face of thyroidectomy or ablative therapy with radioiodine. If that is what is causing the hypothyroidism, then combining T3 and T4 will be a welcome development. We will not combine T3 and T4 in older patients. In anyone with underlying cardiovascular disorder, not in pregnant women. Combination therapy could be all this. You can pause and go through on your own. I don't want to keep my audience for too long. Some are not in health field at all, so they don't need to bother their head about it. Now, T4 low dose is expected in my grandfather, and you can start with as low as 12.5 microgram daily. And also in coronary artery disease, you go low from 25 microgram daily. T4 high dose is expected. Remember, we've just seen T4 low dose is expected in elderly and in people with, coronary artery disease, right? But in young kids, see this, in neonates with congenital hypothyroidism, please don't pity him or her like you will do when it comes to my grandpa that will give 12.5 microgram. No. Go for something higher in them. So young, you can start from 1.6 microgram per day. I'm not saying you should give 1.6. You start from, you can increase. Healthy patient from 1.6, you can go up. Children from 1.6, you can go up. T4 to be taken on empty stomach at 30 to 60 minutes before breakfast. No excess iodine or iodine-rich foods like kelp or seaweeds while on T4. No soya diet per oral, please. If on lithium or amiodarone, etc., watch out. On follow-up, we will reevaluate the patient. Every 6 weeks after the onset of the therapy, we will reevaluate the patient, we'll do thyroid hormone test. We'll adjust the dose based on the value of TSH. We'll titrate, right? Up and down. We'll assess symptoms changes and resolution in 2 to 3 weeks. We will expect TSH to stabilize in 6 weeks. If TSH is persistently high, then we would like to find out if the patient is truly taking the medication as prescribed or as directed. You may increase the dose of T4 after discussing with endocrinologists and pharmacists. It is better to remain on the same formulation. So, as a good way to handle hypothyroidism. The differential diagnosis of hypothyroidism. Oh, this is looking yummy, right? Somebody wants to eat. Your appetite is increased. Sorry. Okay, let's go to differential diagnosis of hypothyroidism. We will not waste time here going through differential diagnosis. So it can be primary hypothyroidism, can be increased chorionic gonadotropin in early pregnancy, mother pregnancy, or choriocarcinoma. Might be central hypothyroidism. Might be related to drug, dopamine antagonist, sodium hypodate, amiodarone. It might be TSH producing pituitary adenoma, adrenal insufficiency, heterophilic antibody interference, generalized thyroid hormone resistance. Can be other situations like Cushing syndrome, anemia, kidney disease, liver disease, depression, pregnancy, diabetes mellitus, pyelonephritis, diet, and sedentary lifestyle. So when the clinical signs and symptoms are presented, it may not be hypothyroidism, can be any of these. And the other time I mentioned medications, I just mentioned few of them, might be more than that. So Now we are at another bus stop, but this is not the bus stop that we've not entered before. Hashimoto's thyroiditis. We were here before. You can pause and rewind. You will see that. But I did something then which I've decided right now to correct. I brought out some facts, typed them, and showed the slides, but I rushed. No, I just towards the end, I didn't show some slides. I just scanned through, presented everything of the slides. So now you will read everything, but something will be different. I won't talk much. You can pause and go through if you choose to, because I'm watching the time. I don't want to weary you. Now, other names for Hashimoto's thyroiditis will be this. Hashimoto's thyroiditis will be the major part of hypothyroidism story, without which the story of hypothyroidism will be incomplete. Now, women to men is 8 to 1, respectively. Okay? Hashimoto is the common cause of hypothyroidism in the Western world or our insufficient countries. And you can pause and read through this. Remember I said I have spoken a lot before on Hashimoto's, so I'm not going to waste your time speaking a lot now. Can also be this. Risk factors, I've talked about that before. Still on risk factors, you can pause and rewind. Mechanism, I've not gone through that before. Clinical features, I've gone through that before. Diagnosis, yes, I just mentioned diagnosis the other time. I wrote it down, but I went through what you could do verbally. Now you can pause and really read them. Still on diagnosis, you can pause and read them. Treatment, I did not give the slide like this before, but I went through what you could do. Now you have the chance to pause and go through. Warning, you can see again. I've said about it before. Avoid LD. Avoid soya-rich diets while you are on levothyroxine. Complications. I've gone through this before. Now you can pause and read through. Complications in pregnancy. I've gone through this before. You can read. Now, lithium and thyroid gland. And they said, oh, Kosi fire, is it winter time? No, yeah. I'm not in winter right now. It's summer in my country, but in some parts of the world might be cold there. Okay. Lithium and thyroid gland. Why have I brought these out separately? Why not amiodarone? I have a separate presentation on amiodarone already, but because people would not likely imagining that they have mood disorder, they are seeing psychiatrists, and now they are down with having excessive coldness and so on, they won't attribute it to the lithium. So let's go. This is a bus stop where we need to pay attention very well. If you're on lithium or somebody around you is taking lithium, or your physician, your patient is taking lithium, then let's go in. Lithium effects on thyroid gland, both good and bad. We address right now. The lithium. Lithium is useful in psychiatry for mood stabilization. the treatment of mania, and even in bipolar depression, and also in prophylaxis in bipolar. Lithium effects on thyroid gland. Thyroid hormone secretion will be inhibited by lithium, leading us to hypothyroidism most of the time. There might be goiter development and also thyroid autoimmunity or autoimmune thyroiditis might come after the use of lithium. Hyperthyroidism might be the case in some, but not very often or common, only seldomly. And there will likely be decreased liver deiodination. For the past 2 years here on my channel, my focus has been on how to assuage the problem. So we cannot say that people should not take lithium anymore. That would be stupid. But if they are taking lithium and we want to save the thyroid gland, what are we going to do? We have physical examination, we have investigations before the lithium commencement. So we can have physical examination for thyroid-related pathology and of course for lithium toxicity in individuals already on lithium. Then we embark on thyroid function tests to be done, and we will be checking thyroid function tests every 6 to 12 months for years. Then anti-thyroid peroxidase antibody will be assayed. Then we can have ultrasound done to focus on the anterior neck for goiter screening. And then we'll regularly monitor the level of lithium itself. Lithium can lead to goiter, and that is the most common abnormality. And that will occur in about 50% of cases. I mean, people taking lithium, right? In that case, you find your your thyroid function test giving you low T4 with or without low T3, with increased TSH, decreased thyroid iodine uptake, or increased uptake. There might be increased thyroid gland size. Of course, that will be goiter. Alteration in the function of insulin-like growth factor is a possibility. Also, tyrosine kinase proliferation may occur and beta-catenin signaling. Diffuse goiter or nodular goiter might be the case. All this is likely going to happen the first 2 years of treatment. It might be earlier in some patients. And how do you treat this? I mean, how do you treat goiter? Okay, you know what to do with lithium first, and then you deal with goiter. You can check my channel for full treatment when it comes to goiter. Now, hypothyroidism and lithium is going to be in about 50% of patients taking lithium. It may occur with goiter or without goiter. Usually, the hypothyroidism will be subclinical hypothyroidism, meaning the TSH is high, the T4, the T3 will be within normal range, may likely be within normal range. Few will have overt hypothyroidism, full-blown hypothyroidism will occur in few. All will happen the first 2 years of treatment, but maybe earlier in some. It's likely going to be more in women that are greater than 45 years, and the likelihood will increase with increase in age. Okay, if we have patients that are on lithium and then they are battling with hypothyroidism here, how do we treat? Well, the answer is right here. You've gone through treatment of hypothyroidism, so check my channel back. But pay attention to this. It is not compulsory to discontinue lithium. Really? But have that pause conversation with your psychiatrist. Let me explain further. Remember, we said that lithium and hypothyroidism will likely give us subclinical hypothyroidism. So if the problem is subclinical hypothyroidism, meaning it's not overt hypothyroidism, the symptoms are not so classical, they are not so acute, they are not so intense, they are not disturbing the life of this person. So why are we going to take off the lithium that is working well, if it is working well anyway, that is working well to handle the mood of this person? Remember, if we wait, subclinical hypothyroidism is lesser of an evil compared to mood that could swing to the negative side, that the person will likely commit suicide or even kill somebody. So in that case, we want to prevent the mood instability and then continue with the lithium while we'll be monitoring what is happening to the thyroid and then the thyroid hormones and salvage the thyroid hormone problem at the same time that we are on lithium. Remember, the individual cannot be on T4 indefinitely. No, that's not going to be the case. If that is it, then we have to be checking for TSH level. Once the TSH level is below normal, then we'll have to be tailing off T4 and discontinue later on. We don't stop levothyroxine, T4, abruptly or cold turkey. No. As a matter of fact, all medications that are affecting the system in the body cannot be stopped suddenly. No. So we'll tail off for a long time, as long as 1 to 2 months, and then we'll assay the TSH again. Then, if TSH is rising above normal, we'll give the T4 again, and we'll continue back and forth like that. So a good patient-doctor relationship will solve the problem. Chronic thyroiditis might be another hurdle to cross here. It is unknown if lithium can induce thyroid autoimmunity. It's strongly believed that thyroiditis is probably in those with underlying chronic autoimmune thyroiditis. Lithium can also enhance the activity of B lymphocytes. So what this is saying is that if somebody is already having underlying chronic autoimmune thyroiditis and now on lithium, then it can shut it up. Hypothyroidism might be the case with lithium, but I will do less here because the topic today is hypothyroidism. So you can pause and read through. If you want me to talk more on this, meet me when it comes to hypothyroidism A to Z. Lithium in the treatment of thyroid disorder, not a first-line medication. You could see the irony of life. Some people are running away that lithium will destroy my thyroid glands. Some people are even using the same lithium to deal with some thyroid problem. But I won't do much here because we've said it, that lithium will lead to subclinical hypothyroidism. So you should guess where will we use it positively in thyroid-related issues. That is in hypothyroidism. But I will not, if you want me to say more on that, meet me, when you click on my presentation on hypothyroidism A to Z. That'll be out very soon. Lithium increases the effectiveness of radioiodide. Can't you see? And we use that mostly in hyperthyroidism. So I will not go into details right now. In thyroidectomy, when are we going to need thyroidectomy? In hyperthyroidism, not in hypothyroidism. So lithium is pretty useful there. You know what? So many medications that we prescribe today, that many patients are taking worldwide today, were not manufactured for those purposes. We make use of their side effects to the good of the patient. You can see now, the side effects of taking lithium, even prescribed for non-thyroid related issue is subclinical hypothyroidism. Now we are using it. We are using that subclinical hypothyroidism as side effects of lithium to deal with hyperthyroidism. Can you see? No, in thyroid cancer, I'm not going into that right now. When we are dealing with hyperthyroidism A to Z, please meet me. You could see the reason why you have to subscribe to this channel, because I will continue to pump up to the time I can no longer talk. Finally, be careful about the toxicity of lithium when you have chosen to use it, even in the face of hypothyroidism. And of course, let your physical examination and every necessary things be done, including thyroid function tests every 6 to 12 months for years. Anti-thyroid peroxides and antibodies should be assayed up to the of the neck. Regularly be monitoring the lithium level. That's the end of lithium and thyroid gland, but that is not the end of this presentation. I know you are weary. Okay, I'll pause a bit now and come back. Okay, I am back. Hashimoto's encephalopathy. And this will be the last bus stop. Hashimoto's encephalopathy. This is not Hashimoto's thyroiditis only. Hashimoto's encephalopathy. From this, you can tell this is bad. The brain is affected. The brain is in trouble. Hashimoto's encephalopathy has the good side of it. Really? Someone is asking. Any good can come from that? It is rare. It is rare. It's no longer common. That is the good news. And it's associated with Hashimoto's thyroiditis. It is steroid responsive. That is a good news. So, you see, I said the other time when we're talking about treatment of hypothyroidism, I said it depends on the cause. That's why thorough history go through the causes of hypothyroidism. So if it is this and you grab your steroid, you are going to win the battle. But there'll be increased antithyroid antibodies. That's how we'll make the diagnosis anyway. Thyroid function tests will reveal hypothyroidism, but could be euthyroid. No other causes of encephalopathy right here. So you have to rule other causes of encephalopathy out. Yes, we have to read it out before we will narrow the diagnosis down to Hashimoto's encephalopathy. Could even be in the face of euthyroid, is more in women with possible HLA-B8 DR.W3 positivity. The pathophysiology is not quite known, but it could be due to toxic effect of thyroid stimulating hormone. Remember, thyroid stimulating hormone will be high in hypothyroidism. Okay. All features of Hashimoto's thyroiditis will be found here, and all clinical features of hypothyroidism will be found here. So you can pause and rewind and go through the features or signs and symptoms of hypothyroidism. So goiter, painless, subclinical hypothyroidism, later on become overt hypothyroidism, all will be found in Hashimoto's thyroiditis with increasing distortion of the thyroid gland. The thyroid gland will shrink, then the goiter will disappear. All will be found in Hashimoto's. Additional clinical features on top of the clinical features of Hashimoto's thyroiditis will be, it can be acute or subacute in nature with confusion. Altered level of consciousness. What are we talking about? We said Hashimoto's encephalopathy. The brain is affected, the brain is suffering, the brain is damaged. And then confusion. Level of consciousness will change. There may be seizures, generalized tonic-clonic or focal seizures. Might even be status epilepticus. And when you do your reflexes, will be high, upper reflex. There may be psychosis, visual hallucination, paranoid delusion, or myoclonus. All because the brain is suffering right now. How can we make the diagnosis here? We have to take thorough history. I've said it earlier. I'm not going to waste your time. Past medical history, autoimmune diseases, no family history of thyroid disease, hepatic encephalopathy. Remember why the history here is a bit different right now? Because we are talking about encephalopathy and we want to be sure it's not something else that is responsible, that it is actually and truly only Hashimoto's that is causing this encephalopathy. So we want to be sure, and we'll then rule out hepatic encephalopathy, uremic encephalopathy. We want to be sure it is not hypoglycemia. Just taking the blood glucose alone may change the course of action. We want to be sure it's not hyperglycemic coma. Is it trauma? They've hit this person in the head, or drugs, alcohol, street drugs, snack comatose. Psychiatry history will be taken, and of course, full physical examination. The diagnosis. The first thing we'll do here, because it's affecting the brain, is lumbar puncture. And then we'll tap our CSF. What are we looking for? We're looking for the presence of increased antithyroid antibodies. That is the clue to Hashimoto's thyroiditis. Wow. But before you will put your needle to time that CSF, make sure that there is no sign of central nervous system increase in intracranial pressure. So you might do CT of the head if you are confused before you run into trouble. So after CT of the head and features and everything about increased intracranial pressure is ruled out, then do your lumbar puncture, get the CSF, look for antithyroid antibodies in the CSF, and make sure there are no signs of infection in the CSF, no signs of neoplasm in the CSF. So with antithyroid antibodies present and your protein, your mycobacterium, tuberculosis with alcohol acid fast bacilli, your gram staining, your white blood cell count, all are saying no, 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 no. And then cells, pointing to neoplasm is also negative, then you are comfortable to label this person as having Hashimoto's encephalopathy. Secondly, you do your thyroid function test. Here you can have subclinical hypothyroidism or overt hypothyroidism. It can even be hypothyroid, and small percentage will have euthyroid. Thirdly, you can use immunosuppressants. If you administer your immunosuppressants and then you get a good outcome, meaning your immunosuppressants are handling the autoimmune condition known as Hashimoto's thyroiditis for you, and then the patient has improved, then you are done. Woo, bravo, you are done. So fourthly, you can head to the lab and also radiological investigation, so you have complete blood count, electrolytes, glucose, liver function test, renal function test, toxicological screening, urine, blood, microscopic conscious sensitivity, no specific EEG. If you do EEG, that is electroencephalogram, not ECG. Electrocardiogram, no. This one, brain waves, no. Want to see what is causing the seizures. You will not get anything specific here. Then you can have magnetic resonance imaging done. But remember I said earlier, you can do your CT scan before you do your lumbar puncture, okay? How do we treat, Hashimoto's encephalopathy? We've seen it, immunosuppressant. For example, methylprednisolone. In fact, there is a separate presentation on prednisone and prednisolone, the similarities and differences, already published by me. Check my channel for that. Azathioprine can be used, intravenous immunoglobulin or plasmapheresis. All this will help. The big problem that could be solved by immunosuppressant. Now, a conclusion. Wow, I made it. I've been struggling to make sure we will not reach 3 hours, and we are done at 2:50 something. Oh, great. So that you can spend the remaining 8 minutes to relax. End of Hashimoto's encephalopathy means end of all presentations on hypothyroidism, as far as I'm concerned. Replay if necessary, because this is pretty long. Drop your comment or comments, because it's not likely you have any more questions on hypothyroidism, A to Z of hypothyroidism. Share with everyone, please, on your platform. Put it external outside YouTube, everywhere, WhatsApp, blogs, everywhere, Facebook, send it everywhere. Let everybody be fully educated. And this is coming to you free. Thanks to YouTube for giving me the platform to reach the whole world. Hypothyroidism A to Z. Share with everyone. Thank you for listening. Remember to subscribe if you haven't. Please kindly share this with every human being. Let's save more lives. I appreciate it. Thank you. Thank you. Thank you for your time.